Okay, so my name is Cassidy Cousens, and I'm a certified substance abuse counselor and interventionist. And over the course of this little video series, we've been talking about a few general concepts. And we started with how to conduct a motivational intervention if you're doing that without a professional, just as a family. And then we sort of moved into what you might expect when your loved one, the intervened on person, goes to treatment, and some of the things that might come up during the process, related ultimately to their addictive pathology, but in some senses pretty common across the board, whether you're intervened on or not. Most people are going to exhibit some form of resistance to the treatment process. We talked about why that was, because they're frightened to surrender these coping mechanisms that, albeit self-destructive in some senses, have been helping them to cope and deal with life. We talked about denial, which is also not unusual. That's not specific just to the intervened on person. A lot of people exhibit some form of denial, be it about their addictive pathology and that self-destructive process, or even sometimes the recommendations that are being made at the center, denying that those recommendations are valid and appropriate in order to sustain a recovery process. And then we talked about in the last video splitting and triangulation and some of the things that you might expect with the person in treatment sort of keeping everybody on different pages, ultimately trying to get certain needs met, or at least things that they quantify as needs, although we discussed those not always being actual necessities. But more importantly, the concept of just keeping people on different pages and distracting the treatment process so that there's a lot of effort and time being put into sort of putting out the fires all around the treatment, and how that serves ultimately the intervened on person and not having to focus full attention on themselves and essentially whether or not they're willing to take the recommendations for success. And, as I was sort of examining the videos, that one of the things that I realized is that when you're communicating like this, when I'm talking with you, it's very hard to address the specific examples that you might have. And I can't stress enough how this whole series is just a general guideline for certain things that might come up. And, being a believer in the integrated model of care, which is that really individualized component, how you will approach certain aspects of denial or resistance or splitting behaviors or triangulation, or even how you'll go into the intervention, will be based on your own intuition. Ultimately, at the end of the day, you've got to take this information, filter it, see what parts of it make sense, and then decide how you're going to approach your loved one. And as much as this is really important information, it's also just general information. So what I wanted to talk about is, how do you use your intuition? How do you know what is the appropriate thing to do? And it's going to be tough to cite specific examples because I don't know precisely what your loved one, the person in treatment, is going to struggle with. I can assure you that there will be some struggle, and it will require you to think on your feet and adapt in order to assist them in finding a way through those obstacles in order to disengage from the addictive pathology and re-engage or engage healthier coping mechanisms. So what that breaks down to is you having the capacity to sort of listen to your own heart, to listen to your own intuition, and to make a discernation in certain moments between what the facility is ultimately saying, depending on the modality that you're in, the counselor, therapist, psychiatrist, doctor, and what the client is saying, your loved one who's in treatment, the intervened on person, what your family is saying, what your friends are saying, what other people around you are saying. Ultimately, you're going to have to discern all that information and try to make the best decision possible that you can that keeps in mind the long-term best interests of the person that's in treatment. And it's really easy for me to say, defer recommendations to the center. And as I was sort of looking at that in the shape of the videos and sort of seeing that that was a consistent theme, that you have to defer recommendations to the center, one of the assumptions that I made was that, in the video, How to Conduct an Intervention, and giving you sort of the basic guide of how to go about preparing yourself for an intervention, one of the things that we talked about was you investigating your treatment options. And we sort of went through how you can ask certain questions, and we described behavioral treatment and evidence-based treatment and clinical treatment and integrated treatment. And the assumption that I'm making is that you're now in a position where the person is in treatment, the intervention has been successful, and you have fundamentally vetted the program that they're in. So you believe in the modality, you believe in the process, you like their approach. And what it overlooks when I do that is the challenges that you might be faced with those recommendations that are being made. And so, in sort of stepping back and looking at this for a second, I wanted to assure you that you have every right to question clinical procedures. And you have every right as a parent or a family member or a loved one or a person that's involved in this client's care, this intervened on person's care. You have every right to ask questions and seek explanations for why the treatment is unfolding the way that it is. And the truth is that good facilities are going to explain to you what they're doing and why they're doing it. Obviously, that's if there's a consent to release information to you in place from the client. So as an adult, this is all sort of focused on the adult side of things. Obviously, if there's someone who's an adolescent, the intervention process would look very different. You could just force them into treatment. You could say you have to go and they'd go. It would be involuntary. But on the adult side of things, 18 and up, there really is no method to involuntarily holding someone short or long term in a treatment setting that deals with mental and behavioral health issues unless they're going to be potentially a harm to themselves or other people. And even on those very severe psychiatric holds, they're usually not long term. You know, maybe 3 days, maybe 5 days, maybe 10 days, maybe 15 days. So you don't really have the same leverage points with adults as you do with adolescents, and you have to be a little more finessed about how you approach it, thus the intervention. And that doesn't mean that you have to defer trust to the facility if they don't warrant it. In other words, when you ask questions, when they make recommendations and you ask questions, you should get a full explanation about why that recommendation is being made. And what you'll often discover is that the recommendation has to do with some form of ongoing treatment. Maybe continuing residential care, maybe transfer to sober living, like a lower level of care after the primary treatment, maybe transfer to an outpatient program, be it a day program or an evening program, depending on how the modality is structured that you've placed your loved one in. Sometimes psychiatric care, sometimes ongoing psychological care, sometimes ongoing individual therapy or counseling. There could be any number of different things, but ultimately recommendations typically are going to be related to ongoing treatment measures. And the reason for that is obvious. We've talked about it, you know it. You can break the cycles of behavior, you can break the patterns, but to stay clean, to stay sober, to stay healthy, it often requires, support, accountability, and structure in the afflicted person's life in order for them to be able to not slip back into old patterns of behavior, thinking, and experiences, or places sometimes where they're going to be prone to relapse. So ongoing treatment is really like the fences along the process of recovery that helps them achieve a point where complete independence is not only plausible but realistic. And that means that they could not be self-destructive without someone looking over their shoulder, examining the decisions that they're making to help them see, if they play this tape out, if they do X, Y might occur, or if they do A, how B might occur. So you don't necessarily need that forever. Some people need it, for 90 days, some people need it for 6 months, some people need it for a couple of years, and I don't mean necessarily in a residential setting, but some sort of accountability going forward. So the recommendations almost always in the facility are going to be related to these ongoing treatment protocols and these ongoing forms of structure. And you deserve an explanation about why. And the key point that I want to make is that We talked about resistance on a sophisticated side. We talked about denial on a sophisticated side. We talked about splitting and triangulation on a sophisticated side. And we talked about the simple, mundane elements of each of those circumstances. But on the sophisticated side of things, a lot of times what happens for families is their loved one says, and this might be partly because they just want you to be proud of them, that everything's going well. And when they call you or when you see them during visitation days or during the family program, however the treatment center that you went to is structured, when you interact with them, they say everything is going well. And then in the treatment, in the day-to-day grind that you don't really see, they might be resistant. They might be in denial that certain recommendations are advisable. They might be splitting, different staff members, asking for one thing from one, not getting the answer they're looking for, going to another staff member, and exhibiting this sort of childlike behaviors of addictive pathology. I want what I want when I want it, and that doing well definition doesn't necessarily apply in the day-to-day treatment process. And so in that circumstance, which is natural and normal, because it takes a little while to surrender some of these coping mechanisms, the treatment center is going to say more time is necessary. And it can be confusing for you because you're hearing them tell you that they're doing well. And the client might be telling you that they're doing well. And they might not be arguing with you. You might not feel the same way in terms of your interactions with them as you had prior to them going into the facility. They may sound better. They may be building language about how to approach themselves and personal responsibility that sounds good to you, that's different from when they were in their active addiction and they were essentially blaming everyone else for their issues. There might be a removal from some of those perceptions, at least when it comes to you in the form of the conversation that you're having with them. And it might be that they're telling you they're doing really well, but you're hearing from the center that they need more treatment, and specifically they need more residential care, or they need more sober living, or they need to go to an outpatient program. And it gets confusing because you're hearing the client, your loved one, the intervened on person, tell you that they're doing well. They sound better, but the facility is saying more time, more time, more time. And one of the first things that comes up is it monetarily motivated? At least it would for me. If I sent someone, it's like going to buy a car. If you go to buy a car, you're not through the process until you've gotten through the finance department. And when you're in the finance department, they're going to offer you all these add-ons, like gap insurance or any number of different things that are quite expensive over the long term. And so, once you get through that process and you're out of the finance department, you sort of feel like you've got the car, it's your car, you can drive it off the lot and you're free and clear. But in treatment, a lot of times the same sensation will come up when the facility says we recommend that your loved ones stay in treatment longer or go to an aftercare program or any number of different recommendations. And that's natural. That's absolutely normal and that's absolutely natural. And I wish that I could tell you that every program in the United States made recommendations based on clinical need. And they don't all do that. But I'm hoping that when you've vetted this program, the program that you've chosen, that you ask them questions about, what does ongoing care look like? How do you individuate the treatment process? What determines that someone is ready to go and what determines that someone needs to stay? And they've explained all this to you. But in the event that you didn't ask those questions, you didn't ask what progress in treatment meant and what goals and objectives needed to be reached in order for them to graduate from one level of care and go to another level of care, or what connotated success so that they could be determined eligible to be able to continue this recovery process by themselves. If you haven't asked those questions and you get a recommendation from the facility, they need to do more treatment, ask those questions. Say, what are you seeing that we're not? Because X person, the intervened on individual, is telling us that they're doing really well. What are the indications that more treatment in this form is necessary? And, ultimately what you want to hear is that there's specific objectives that are understandable to you that have not been met. And it might be that they're not accepting that they have a substance abuse issue or an eating disorder or a gambling problem. For example, they might be saying, I have a problem with Xanax, but I can still drink, but the facility is afraid if they drink, they're going to lubricate the neurochemistry of addictive pathology and possibly set themselves up to be more susceptible to using Xanax. It could be that. It could be that a gambling addict is in treatment because they've been playing cards and they're saying I can still bet on sports. And the treatment center knows as soon as they engage that addictive pathology and they involve themselves in sports betting, all the game is done and they're going to be back being a deplorable, degenerate gambler in no time. So, you want to hear them tell you the reason that we're saying they should extend treatment is because they're not aware that alcohol is potentially very dangerous to the recovery process. They're saying that Xanax is a problem, but they still want to be able to drink freely. They're willing to surrender cards as a gambler, but they're not willing to surrender sports betting. And because of those reasons, we need to continue to work with them to raise their level of insight into understanding that if they engage alternative forms of addictive pathology, they're just going to end up clouding this whole picture very rapidly and be right back where they started in no time. So we want them to be abstinent from gambling entirely. We would prefer that at least for 6 months to 12 months they remained abstinent from all mind-altering substances. And until we see that concession on their part, we think that more treatment is advisable. And once you hear that, you'll probably find that your heart understands it and that intuitively it makes sense to you. And what then you can do is defer the recommendation. You can say to the loved one, to the person that's in treatment, we've spoken to your counselor, they've said X, we understand what they're saying, we love you, we want you to get all the help that you can, we want you to build a solid foundation and ultimately be able to move forward successfully. Interestingly enough, when you back the recommendations, that's usually when you find out whether this was a sophisticated or mundane form of denial resistance or triangulation. Because a lot of people will act as though everything's okay in the treatment process as clients until they find out they're going to have to do more work. And rather than do the work, they're more invested in arguing with you, their therapist and their counselor, or whomever is assigned to their case in the treatment program that you've chosen, and argue with all these individuals about why it's not necessary. And the reason that that's important to understand is because, what you're hoping to achieve here, and this is just a basic fact, this isn't science, but what you're hoping to achieve here is you're hoping to achieve a state of open-mindedness to suggestions that are really valid at their core. It's not a ludicrous statement to say to someone who's abusing benzodiazepines, alcohol affects the same part of your brain as benzodiazepines, and you're going to be more susceptible to lowering your inhibition and your ability to say no to benzodiazepines if you drink. That's a real basic truth. The reality is that not drinking is very advisable for people that have exhibited substance abuse pathology with just about any drug, right? And you'll probably understand that in its barest form. But what's important is that you be explained to why these things are being recommended. So I really didn't want to end up in a situation where I didn't acknowledge that, at least at some point during the course of this video series, that it's very hard to defer recommendations to a facility. It's tough to trust a facility. And you have done the research and you believed that this modality was the right modality for your loved one, the person that's in treatment. And you really do gain a lot of knowledge when you back the facility's play. It doesn't mean at the end of the day that the client, the intervened on person, is going to follow the recommendations. But sometimes you want to open up the thought process and show them clearly that everybody is on the same page. We all think that 30 days of treatment was really great. We commend you on doing it, and you've done well in the process. In the meantime, we don't want you to leave the facility without some sort of ongoing support. Do you understand that? And the client might say, I don't. I don't want to do it. I don't think it's advisable. I don't think it's necessary. And they might relapse. And the truth is that although that's very dangerous, we talked about relapse not necessarily being a part of recovery, but sometimes being a part of the recovery journey. If everyone can stay in contact with the individual that doesn't take recommendations, a lot of times you're going to be able to catch these relapses quickly, and then you can restart the treatment process. For you, it's going to be expensive. At the end of the day, you don't want that to happen. So my advice is to back the recommendations of the facility, to make sure that the treatment episode is productive, that the person in treatment gets everything that they possibly can out of it. And the best way to do that is not to interrupt it. Like, you don't want to complete 30 days of treatment and then the client says, I want to go on vacation to Aruba for 2 weeks and then come back and finish treatment. I mean, you would never recommend that for your friends. Don't recommend it for the person that's in treatment. They need to be consistent. Aruba is dangerous. They just got out of treatment. It's potentially very risky to their recovery. They might end up getting loaded. And so stay the course, follow the recommendations, continue the treatment process until it concludes. And it will conclude. Inevitably, the goal of this process is that someone becomes self-supporting and independent in their recovery. They might end up choosing, a 12-step program or a smart recovery program or an individual therapist or a psychiatrist. They might end up choosing their own ultimate support network in the future. But the reality is that it's going to be a voluntary choice. They're not going to feel the compulsion and cravings that they used to. They're going to have healthier coping mechanisms for how to manage and deal with life productively and effectively. And it's absolutely plausible that they can transform themselves into, not necessarily me, but what you see people in recovery being, right? Years ago, I weighed 127 pounds and I'm shooting drugs, right? And today that's not the case. And the reason that it's not the case is because I finally decided to follow treatment recommendations. I had a family and a group of people around me that was willing to co-sign the facility's recommendations. And all avenues escape from my addictive pathology were cut off. And I was essentially force-fed the seriousness of the situation long enough that I bought in. And once a person buys in and they start to feel better, that's usually what happens. They start to feel better, doing the right things, telling the truth, being open to new ideas, being willing to follow suggestions feels better. I no longer needed to anesthetize myself to distract and relieve and cope with pain. And more importantly, my co-occurring issues of depression and anxiety started to be nominalized and worked out with the help of a psychiatrist. So what you want to achieve for this individual is the same thing. You want them to be self-supporting in their recovery process. You want them to be able to do the right thing when no one's looking. You want them to feel better about themselves, to not feel compelled to anesthetize themselves or self-medicate themselves. And that is not only plausible, it's achievable. And it requires everyone to be on the same page that these recommendations are valid, but it doesn't diminish the idea that you might need an explanation about why the center is saying X, that they need to stay longer, that they need to go to this level of care after this. You're completely authorized to ask questions and say, will you explain to me why you're recommending that? And, usually the facility is going to be very detailed in why. They'll have a list of reasons why this is necessary. One little caveat, and then we'll close, is that if they say, I can't talk to you, the release of information has been pulled, I don't have a release to communicate with you, under no circumstances should you then follow the client's own recommendations for themselves. So if the intervened on person goes into treatment, they say to you on the phone, everything's great, I'm doing well, but they don't keep a release of information in place to be able to communicate with you, you know that there's a major split. That if they're doing well and they're insightful and they're participating in the treatment process, there is no reason that you shouldn't be made aware of that. These aren't secrets that the facility is going to be sharing with you about their past and all the shameful corridors of their experience in addictive pathology. The reality is that the facility is just going to say prognosis, good, fair, poor. I mean, it's just going to tell you based on what they're experiencing with certain goals and objectives whether or not the prognosis for this individual is good, fair, or poor. And if the client doesn't want you to even know that information, more than likely they're on the poor side of things. And the prognosis is not looking good. They're probably not participating with the level of insight. They're probably exhibiting a great degree of denial and resistance and splitting and triangulation behaviors. And at that point, if you don't have a release of information in place, 3rd week into treatment, 4th week into treatment, under no circumstances should you co-sign the person leaving the facility without support. You would be essentially co-signing that they continue to use. So hope that makes sense. Feel free to ask the facility that you've chosen questions about why they're making the recommendations that they are. And 9 times out of 10, they're going to make sense to you. Make sure that you assemble all your inner resources to be able to listen openly, because the client might have been telling you that everything's good, and the facility might be saying that's really not the case. So be open to what they're trying to communicate to you as a facility, and try to make the best decision that you possibly can based on what's in the best interests of your loved one's long-term care. So I hope that made sense, and we'll be talking again soon.